Hi friends, myself Dr. Ayush. So at Game PG we have decided that with the Fmge exam upcoming, we shall be discussing in form of YouTube videos around 3 to 4 important questions which have been previously asked in your exams and some important concepts or points related with it. So let's begin our discussion for today. So you have in your screen your first image where you were asked about the diagnosis. So as we all know that this is an image of an esophagus where you can see over here the corkscrew appearance of the esophagus, right? So this is a corkscrew esophagus. So it is usually present in your distal esophageal spasm, right? Important questions that can be asked with respect to is the most common site of location, which is usually your distal to third, and it usually presents with chest pain and dysphagia. Important topic with respect to this is the esophageal motility disorder classification, which is your Chicago classification. This image has been taken up from Bailey and Law, where you have your third version of the Chicago classification. However, in February 2021 we have had a recent update where the fourth version has come, and we might get one or two questions from that classification where we would be discussing a little bit of it. So coming first to the previous edition, which is mentioned in most of your textbook. So here we have the distal esophageal spasm, right, where you have your normal median IRP more than 20% premature contraction, BCI more than 450, and some normal peristalsis may be present. So in such charts you might get questions regarding asking about their DCI values, where you need to classify whether it's a type 1, type 2, type 3 achalasia. So now let's come down to the recent update of Chicago classification as you see in this version. So the image might look complicated to you, so what we'll do is we'll simplify and try to understand what have been the changes. So let's talk about our first change. So the first change states that there has to be further manometric and non-manometric evaluation required to arrive at a conclusive actionable diagnosis of esophagogastric junction outflow obstruction. So if you would see, the previous one was mainly much more of manometric values. So in this new classification, they have given a lot of importance to the non-manometric values also. Secondly, esophagogastric junction outflow obstruction, distal esophageal spasm, and hypercontractile esophagus are three manometric patterns that must be accompanied by obstructive esophageal symptoms of dysphagia or non-cardiac chest pain to be considered clinically relevant. So as you had seen in the previous slide when we were discussing the question, we had mentioned about this symptom. So in order for this to be relevant, it is just not just a manometric finding. Now we need to have such clinical symptoms to be present along with it. The third important change that we see is that standardized manometric protocol should include supine as well as upright position. So initially there was no change in position that was being taken, but now as well as additional manometric maneuvers such as the multiple rapid swallows and rapid drink challenge. Also, solid test swallows, postprandial testing, and pharmacologic provocation can be considered for particular condition. So it's just not about the reading in one position, rather the change in positions is also considered in the recent classification. And finally, the last change is the definition of ineffective esophageal motility is more stringent and now encompasses the fragmented peristalsis. So it basically no longer distinguishes major versus minor motility disorders as we had seen in the Chicago classification of third version. Rather, it simply separates disorders of EG flow outflow from disorders of peristalsis. So let's not go much into detail. Remember these four important points that might be your potential MCQs for your new classification of the esophageal motility disorder. So let's revise the changes once more. So your changes would be manometric and non-manometric evaluation, right? Standardized manometric protocols include the change in positions. The ineffective motility disorder is more stringent. Major and minor motility disorders have gone away with it, and your it must be accompanied by clinical symptoms to be called it relevant. So moving down with the second question, as we see, it is a simple straightforward diagnosis for you, where you can see bruising over the mastoid area, right? So it is the bruising over mastoid area. So what is this? This is basically a battle sign, right? So where do we find it? We find in skull base fracture. This is usually confused with another sign, which is called your raccoon or panda sign. So what is this sign? This is basically bilateral periorbital swelling. Lateral periorbital swelling. So over here some important points with respect to the skull base fracture. Always remember that blind nasogastric tube insertion is contraindicated here. They usually have rhinorrhea, CSF leakage via nose, and can also have otorrhea, which is bleeding from the ear, right? So it is a bruising over the mastoid area, which is your battle sign, right? So now let's come down to our third question, which is again your spot diagnosis. I'm pretty sure in your internship posting you must have come across this case quite often. So what is this? So basically over here, as pointed out with the arrow mark, this part, it is nothing but air under the diaphragm. So what are the questions that can be asked? It has been asked recently in one of the exams also. So what are the causes? So causes could be a penetrating injury, right? Penetrating injury to the abdomen. Then it could be a bullet injury to your abdomen, or it could be due to some perforation in the hollow viscus, right? Perforation of hollow viscus. So what are the points that it can be in the perforation of the hollow viscus? So number one, it could be due to the peptic ulcer perforation. It could be due to the perforation of malignant gastric ulcer. Malignant gastric ulcer. It could be due to small bowel perforation, right? Small bowel perforation could be because of TB, typhoid, or it could be because of Crohn's disease, and it could be because of large bowel perforation. So large bowel perforation would include again features like Crohn, then it could be ulcerative colitis, and it again could be tuberculosis. So another important point which we will discuss over here in small would be the management, right? So the management would always include your clinical assessment, right? Then it would include, most important point would be your resuscitation, right? So now what would be your resuscitation including? It would be including IV fluids, it will be including nasogastric tube, urinary catheter, right? It would be including antibiotics, which should be your broad spectrum antibiotic. So you will be getting a question, what would be your next step, how will you manage? So you need to assess the question and accordingly answer what is to be done over there, right? So now after this resuscitation, you have your definitive management, where you would do an exploratory laparotomy, right? So in this exploratory laparotomy, always remember it will be a midline incision, right? You need to do a peritoneal lavage and Graham patch repair of perforation. So this is all about your free gas under the diaphragm. The recent exam question had asked regarding the complication of the peptic ulcer, and you would be seeing a free gas under diaphragm. So come down to the next question. So this is an image based question which is basically taken from Sabiston. So what is this? This is nothing but an image of calciphylaxis. It is basically seen in 4% of patients undergoing surgery for secondary parathyroidism, right? So important question over here that could be asked to you is regarding this treatment. It would be surgery. Why surgery? It would reduce your pain, right? We would prefer operating such patient as it would reduce pain, it would improve survival, and at the same time it would reduce your risk of amputation, right? So what you see over here is basically vascular calcification and skin necrosis. So these are some important points with respect to your calcified axis. We have discussed about this detail in our videos. You can always look at the video of calcified axis for this further explanation. So now in this video, this would be your 4 important questions that I would like to discuss. Also, we have come up with a new series which is available in your Game PG app, which is called a NEET list, where we would be discussing some important topics and points which may be asked in your exam, so you may look at them. They are available for free, so keep following the app. And another series that we have come forward with is your surgical anatomy, which could also be available in your Game PG app. So keep following your Game PG app and stay tuned to the YouTube channel for more such videos and important points. Thank you.